the premolar, because of the complete absence of keratinized tissue, apical increased recession, which is not to be covered the root exposure, but is to reduce the risk of further progression of the recession in an area with a complete absence of keratinized tissue. So the flap design is performed maintaining this amount of keratinized tissue in the lingual aspect, because the goal is to recreate a buccal band of keratinized tissue, so I don't need this keratinized tissue in my buccal flaps. And I will use this keratinized tissue to increase the amount of keratinized tissue on the lingual aspect of this implant-supported restoration. So I made an incision that divides the keratinized tissue from the buccal alveolar mucosa, and I verticalized the occlusal keratinized tissue, while in the buccal aspect, I'm raising the flap, deep split thickness, to create an area of periosteum free from muscles, being careful on the position of the mental nerve in this area. So you have to carefully check on the X-ray the position of the mental nerve, being sure with the deep split thickness incision not to reach the area of the mental nerve foramen, because otherwise with the deep split thickness incision you can really make damage to the alveolar nerve. So once my buccal flap made only of keratinized tissue is raised, I can fix it apically, performing the so-called vestibuloplasty, which consists on the apical fixation on the alveolar mucosa, maintaining my recipient bed free for the receiving the free gingival graft from the harvesting procedure. So the alveolar mucosa is secure, anchoring the periosteum on the buccal aspect. So you can take the periosteal and make the alveolar mucosa perforation with the 6O pseudomaterial, TGA pseudomaterial, the 6O with the 11 millimeter long needle. Be careful to stabilize the alveolar mucosa apical with respect to the ideal position of the free gingival graft. Single interrupt suture, alveolar mucosa, and periosteum. You don't have to obtain a first intention closure. What is important is to obtain the stability of the alveolar mucosa in the actual position. So one more suture on this distal aspect, and then we can see the recipient bed, and now we can place the implant in order to be sure that the implants are completely surrounded by bone, because otherwise, if I don't have enough bone thickness and I'm not sure about the implant positioning, or I'm not sure about the maintenance of the buccal bone wall, this procedure can be dangerous, because the free gingival graft is going to survive only if it is applied above a periosteal bed, receiving the vascular supply, because the connective tissue graft in a bilaminar technique survives thanks to the vascular supply that derives from the covering flap. The free gingival graft survives thanks to the vascular supply that derives from the periosteal bed. So if during the implant placement I will have the formation of a buccal bone lesions, the portion of the implant that is going to be applied above the buccal bone lesions is not going to receive the vascular supply. So it's going to have resorption, necrosis in this area. So I can have the complete failure of the procedure. procedure. So you can perform these simultaneous free gingival graft and implant placement only when you are sure on the presence of the entire buccal body wall after implant placement. Because in case of buccal bone lesions, the graft is not going to survive, and the technique should be a bilaminar technique, as we will see in a while. So now the implants are in position, the vestibuloplasty was performed, the recipient bed is ready to receive the free gingival graft, the implant was completely surrounded by bone, no buccal bone lesions, no fenestration, so we trust in our free gingival graft that is going to be extended. Also the level of the premolar, so you see the long graft, which is going to be not disepithelialized, but if we have factor glandular tissue in the inner aspect, we remove it, and then we start with the fixation. Remember, the tissue that was verticalized on the occlusal aspect to maintain the keratinized tissue on the lingual side. So now we stabilize the lingual tissue in the vertical position to recreate the keratinized tissue in the lingual aspect. So we suspend the suture around the implant, maintaining the keratinized tissue that was pushed from the occlusal and the buccal aspect toward the lingual side. In order to maintain these tissues as much as possible, taking into account that on the vestibular aspect, we are going to create new keratinized tissue thanks to the free gingival graft. So we can use the entire amount of keratinized tissue that was remaining in the deltoid area to improve, to increase the keratinized tissue height on the lingual aspect. And then we can simply fix the keratinized, the free gingival graft in the buccal aspect, stabilizing the graft in the coronal position. This is an external mattress suture, incomplete external mattress suture, perforating the graft. The needles comes out externally, and then we come back perforating from external toward the graft without perforating the graft in the way back, but taking deep periosteal angle. So when I pull the suture, you see that the angle of the graft is stretched toward the peripheral side where there is the periosteal anchorage. So it is stabilized and also stretched to the lateral side. Because the same thing is going to be performed on the distal aspect. This is a coronal single interrupted suture, but then I'm going to stretch toward the distal side, the distal apical angle with this horizontal incomplete external mattress suture. So you can see graft perforation, the needle comes out in the attaching tissue, and then I come back from outside toward the graft without perforating the graft, but you see that when I pull the suture, the graft is stretched toward the distal aspect. Then I improve the coronal stability of the graft. Since we have a long one, we cannot, is not enough only with 2 sutures, as in the previous one. We need to stabilize the graft also between the implant and the tooth, and between the 2 implants, in order to have a stable position of the graft. And then we will also perform some compressive suture, taking the periosteal anchorage and the small amount of periosteum that remains free from the free gingival graft and the apical reposition at alveolar mucosa. We suspend the suture around the healing cup and we close the neck. In this way, we are stabilizing the graft in the central portion formation of blood clots with the free gingival graft and the recipient bag. And as you can see, at the end of the surgery, we have keratinized tissue on both buccal with the free gingival graft and lingual, thanks to the verticalization of the residual amount of baseline keratinized tissue. So now we have to wait for the healing and the soft tissue maturation, and you can see that the implant is surrounded by keratinized tissue, also at the level of the recession affecting the second premolar. In the lingual aspect, we have that of vestibule, and this allows the patient to clean in the proper way. So before implant placement, if you don't have any keratinized tissue, during implant placement, if you are sure that the implant is completely surrounded by bone without any buccal lesions, and you have at least 2 millimeters of keratinized tissue, and what happens when you have more than 3 millimeters of keratinized tissue? So when the condition can be considered also not bad without doing anything. But as you can see, we have keratinized tissue, but we have this huge concavity that does not provide the right emergence profile for the patient to clean. Because you can provide the implant supported rehabilitation, but the buccal lingual defect that is not going to allow the proper oral hygiene. So we have enough keratinized tissue, so we don't need to increase the keratinized tissue. If we coronally advance the flap, we trust in the stability of the flap because of the keratinized tissue. So in these cases, we can perform the soft tissue management during the implant placement. So you see in this area we have enough bone in terms of apical coronal dimension, and we have enough bone to place the implant also in buccal lingual dimension, but for sure, like in the previous case in which there were no keratinized tissue at all, if we are simply placing the implant like this, we are going to have a different crown dimension with respect to the RGB, again, not providing the patient the good emergence profile for the implant supported restoration. So in these cases, the technique consists on the coronary advanced flap execution and a tissue level implant insertion that is going to be covered by a connective tissue graft that is going to be attached to the inner aspect of the flap, like during the immediate implant placement, because here we don't have the papilla because the edentus area on the posterior side is flat, so I don't have papilla more coronal to suspend the connective tissue graft, so I will fix the connective tissue graft to the inner aspect of my flap, 1 millimeter per marginal, maintaining my keratinized tissue of the flap free without the connective tissue graft, covering the tissue level component of the implant and applying 2 millimeters of connective tissue graft on the buccal bone to compensate for the buccal lingual defect. And in case of minor buccal bone deletions occurrence, again, I can compensate for them, increasing a little bit the apical coronal dimension of the connective tissue graft to cover the buccal bone lesions, just increasing the apical coronal dimension of the connective tissue graft. So that way, I'm going from one side to, let's say, compensate for the buccal lingual gap, providing the good emergence profile for the implant support for restoration, increasing also the supracranial portion of the soft tissue in that case. because I'm going to coronally advance the flap, placing the connective tissue at the level of the tissue level component of the implant. So with this surgical procedure, performed in the non-aesthetic area in presence of at least 3 mm of keratinized tissue, so it means in presence of a good vesicle depth, I'm providing an increase of tissue thickness that allow to improve the emergence profile and facilitate the flap control for the patient. So I raise my flap, split thickness, and then full, and then split thickness again to obtain the coronary advancement of the flap. As you can see, there is a small buccal bone deletion on the buccal aspect of this implant that is going to be completely covered by the connective tissue graft that is fixed to the inner aspect of the flap. The surgical papilla are free, the connective tissue graft is paramarginal, so at the time of the suturing, I will put the surgical papilla in contact with the lingual flap, and the connective tissue graft is going to be at this level, covering the tissue level component of the implant and completely covering the buccal bone deletions, and the apical part of the graft is above the buccal bone. And the flap is coronally advanced. So this is 1 month and 3 months after, and then at the end, 6 months at the end of the maturation, we can start with the provisional restoration, and then the final one. This is 1 year after loading, and you can see, comparing the baseline situation with the final restoration, that the mucosal margin of the implant supported restoration is in the proper way, thanks to the coronary advancement of the flap that is maintaining that position thanks to the connective tissue graft. And in the profile pictures, you see that the concavity that was present at baseline is completely solved, providing the nice emergence profile for the patient. And this is 3 years after the delivery of the final restoration. And this is the comparison between baseline and 3 years after loading. And this is the video of a similar case that shows you exactly these anatomical conditions, which are very frequent in the posterior area. You have enough bone, you have enough keratinized tissue, but you have to compensate for this lack of tissues, bone and soft tissue, that will not allow to have the right dimension of the implant supported restoration. So you see that the flap is going to be raised with the horizontal incision in the dentus area, raised split thickness at the level of both surgical papilla and full in the central portion, where we are going to raise full thickness the central portion, where we are going to place the implant. Split thickness papilla between the 2 premolar, full thickness intercircular at the level of the second premolar and in the central portion, because the flap is going to be coronally advanced, and we will take advantages of the surgical procedure to improve also the quality of the tissue at the level of the premolar. So we raise the flap. We simply verticalize the tissue toward the lingual aspect in order to have access for the implant positioning. We perform some deep and superficial split thickness incision to obtain the coronary advancement, which is a small coronary advancement. We don't need a huge displacement. When we feel that the flap is passing enough, we remove the epithelium at the level of the papilla between the 2 premolar that is going to be covered by the flap, and then we place guided the implant, because as you saw in the planification, we have enough ball, enough corona. Now you didn't saw the planification, but I know that we have enough ball, enough corona dimension, and in bilingual, but if since the amount of buccal bone, residual buccal bone, is very, very limited, we cannot make any mistakes because otherwise we will increase the amount of buccal foliation that we already know is going to be formed after this implant placement, a small amount of buccal foliations with a thin remaining amount of buccal bone. But again, this is going to be not a problem at all, since we are going to increase the soft tissue thickness. So the soft tissue will be coronally advanced and will remain in that position thanks to the increase in thickness. So we are not worried about the possible exposure of the implant thread, because the thickness will never shrink in an apical direction. So harvesting procedure, you are already familiar with this procedure and this epithelialization. So once the graft is ready, it's 6 millimeters in height, 10 millimeters long, and is 1.2 millimeter thickness. This is the position of the connective tissue that is going to be attached, perforating the base of the surgical papilla of the flap, the graft, then we come back horizontally from the graft, and the needle is going to come out from inner aspect toward the external aspect at the base of the surgical papilla of my flap. With this mattress suture, you see the keratinized tissue which is free, that is going to be attached around the healing cap, and the surgical papilla that is going to be put in contact with the lingual flap. And you saw the small amount of buccal foliations that is visible after the implant placement. So now I can secure my surgical papilla and the lingual tissues, putting them in contact. You see the residual amount of keratinized tissue and the connective tissue that is here, that is going to protect the buccal foliations and is going to increase the soft tissue thickness in the supracrestal portion, ended up with an increase in the supracrestal soft tissue that allowed to obtain, in this case, a completely different situation from an aesthetic point of view with respect to the first case I showed you, the one in which the crown was longer than the actual teeth. And the first case, the choice was pre-gingival graft because there was no keratinized tissue at all. Here, since we had some keratinized tissue at all, we had the possibility to increase the soft tissue thickness, providing this emergence profile. In the previous case, a possible alternative in a patient with a highly aesthetic demand could be pre-gingival graft before implant placement, and then during implant placement, you can increase the soft tissue thickness. And this is something that can be done, and I would suggest, in case you perform that, instead of applying the connective tissue, like in this case, you can maybe apply the collagen matrix that is going to create the volume increase, reducing the morbidity, because